محاضرة perinatal asphyxia, neonatal hypoxic ischemic encephalopathy. Objectives to define hypoxia, asphyxia, ischemia, to illustrate the different causes of neonatal asphyxia. We will demonstrate the effect of asphyxia on different organ systems, including the cardiovascular system. We will discuss the pathophysiologic changes in neonatal HIE, but very shortly. Grading of neonatal HIE will be mentioned. There are 3 grades. I hope I will classify well so as to help to tell the parents the prognosis and decide the management. What about the management? Of course, we'll start with the investigations, supportive measures, and neuroprotection. Let us show you this case of a multi-gravid mother, 35 years age, presented at near term, 39 weeks of gestation, severe vaginal bleeding leading to manifestations of fetal hypoxia in the form of fetal heart rate 100. Emergency section was performed for that reason. The neonatal team is handled a pale limp term infant with a heart rate of 40. Of course, it's very slow, no spontaneous respiratory efforts. The infant was aggressively resuscitated, including of course the positive pressure ventilation, intubation, umbilical venous line placement, through which epinephrine normal saline boluses were given. The uterine inertia was the etiology according to the obstetrician of vaginal bleeding prior to delivery. The cord blood gas showed a very low pH, 6.9, a very low bicarb, -20, the base deficit. At 1 hour of age, owing to the successful resuscitation, she was breathing spontaneously. She had a normal heart rate, but she was lethargic. She was not conscious, but she was responsive and had depressed deep tendon reflexes. We will discuss the appropriate next actions. Hypoxia is defined as partial or complete lack of oxygen in the tissues, and as we know from physiology, there are 4 types of hypoxia. This is one type of them. This is the hypoxic or hypoxemic hypoxia. Is deficient in the tissues due to oxygen deficiency in the blood. What is ischemia? Ischemia is reduction or cessation of blood flow to the tissues, and usually due to decrease in the cardiac output. And so this fetus with a heart rate of 40, of 100 prior to delivery and 40 at birth, and pH is very low, we expect the ischemia, we expect low cardiac output leading to What about asphyxia? Asphyxia is impaired blood gas exchange, CO2 and O2, which if persisting, it will lead to progressive hypoxemia and hypercarbia. The gas exchange will be in the lungs, in the living personnel, and in the placenta in the case of fetuses. So the asphyxia can occur either inside the uterus for the fetus or after birth for the neonate. This asphyxia ischemia will lead to neonatal hypoxic ischemic encephalopathy, and the sequence of events are: number 1, asphyxia, which will lead to hypoxia, and hypoxia will affect the heart, leading to decreased cardiac output, and ischemia All of these factors will lead to encephalopathy. What is meant by encephalopathy is a disturbance of brain function. Here is neonatal hypoxic ischemic encephalopathy because he is a neonate. The main pathology is hypoxia and ischemia. There are more diagnostic criteria to diagnose the neonatal hypoxic ischemic encephalopathy. Number one, evidence of severe acidosis at birth. I mean, the pH is less than 7. Number two, depressed Apgar score. Of course, you know Apgar score. There are 4 items: the respiration, the heart rate, the tone, reflexes, and the color. The Apgar score, if less than 3 or less than 3 at 5 minutes, it's diagnostic of severe asphyxia. Neonatal encephalopathy, or the presentation, clinical presentation, the clinical findings of decreased or affected brain function. Of course, in the fetus and even in the infant, there are trials to conserve the brain and conserve the blood flow to the brain, and as long as the brain is affected, we may expect that the other systems will have the same problem and will suffer from dysfunction. There are many conditions leading or associated with asphyxia. These conditions may be antepartum, intrapartum during the birth process, or postpartum after. Okay, these are conditions, intrapartum or postpartum neonatal conditions. All of these factors will lead to asphyxia, leading to hypoxia, consequently ischemia, and consequently the brain will suffer, leading to encephalopathy. This slide will present what occurs secondly to respiratory depression and circulatory depression. Respiratory depression leads to hypoxia, hypercarbia, and respiratory acidosis, and consequently with circulatory depression will lead to decreased cardiac output, tissue perfusion, ischemia. Anaerobic metabolism will lead to metabolic acidosis, capillary leak, and in multi-organ. Early effects of asphyxia: the riving reflex, trying to preserve the cerebral blood flow, but later on the cerebral blood flow will decrease. The cardiovascular response after resuscitation: there is hyperperfusion, then cerebral hypoperfusion that increase again, and disturbance in cerebral blood flow will lead to saccade energy failure and exaggerated apoptosis and many problems. This slide, in summary, anaerobic glycolysis is a consequence of hypoxia and ischemia, leading to decreased energy or ATP, increased glutamate, affection of the receptors, and increase in the calcium influx into the cells, activation of lipases, and increase in the free fatty acids, and increase in the reactive oxygen species in the brain cells, and the mitochondrial affection and apoptosis and cell death. Of course, the other organs could be affected by asphyxia, and the neonatal hypoxic ischemic encephalopathy is a multi-system disease, as I told you. The brain, of course, there are manifestations of encephalopathy. The kidney, of course, one of the very important organs because it controls the fluid and electrolyte balance. So acute tubular necrosis, oliguria, hematuria, polyuria, and so if we remember this slide later on, this will upon this slide the investigations will depend. For the brain, if we ask about what investigations we should do, For the brain function or the electricity is diagnosed by EEG or EEG monitoring. Also the image of the brain, the best is to do magnetic resonance imaging. For the kidney, which is a very important organ, fluid electrolyte balance is very important to calculate the urine output in order to measure the amount of fluids to be given, and creatinine, of course. For the heart, persistent pulmonary hypertension, secondary to prolonged asphyxia, and a disease of the cardiac muscle, we call it asphyxial cardiomyopathy. This will lead to right to left shunt, that's for the persistent pulmonary hypertension, which will lead to acidosis, and asphyxia cardiomyopathy will lead to decrease in the cardiac output. So here is the echocardiography is important to diagnose such events. For the liver, increase the ammonia, increase enzymes, and the increase in the level of jaundice, but usually this jaundice is one of the late jaundice at the end of the first week, not in the first day. You know, the very early jaundice is characteristic of hemolysis. The gastrointestinal tract in necrotizing enterocolitis. Necrotizing enterocolitis is a disease which is more or less specific for the preterm, but it can occur in any infant with hypoxia and hypoxic ischemic encephalopathy. So for the GIT, we may do abdominal ultrasound or abdominal X-ray, and also we should take care not to feed this infant except if the GIT is benign. Passing stool, no distension, internal sounds are okay. Pulmonary hemorrhage and pulmonary edema are characteristic of the pulmonary complications. X-ray is one of the investigations that may be needed if we suspect those two complications, and this baby may need respiratory support even by ventilation. The endocrines may be affected, and by endocrine I mean two very important glands. The suprarenal gland leading to suprarenal insufficiency, we know that blood glucose in this case will decrease, the sodium will drop, and the blood pressure is dropping. So measuring of the blood pressure, controlling the blood pressure, the sodium management, and monitoring the blood glucose are very important. This will be in the investigations and in the management. SIADA syndrome, inappropriate antidiuretic hormone secretion, will lead to dilutional hyponatremia and oliguria. So again, calculation of the urine volume is important, and this measuring serum sodium is important. Disseminating intravascular coagulation can occur second to hypotension, to asphyxia, and hypoxia. These are the main affection of all the systems in the body. What are the clinical staging of neonatal HIE? SARNET and SARNET demonstrated 3 stages. These stages differ from the mild stage 1 to the severe stage 3. What's the importance of this classification? The importance, of course, is the prognostic value of this classification, because if you look to the end of the column, first column, in the stage 1, the outcome is 100% normal. So these babies do not need except the conservative management, just supportive and conservative management. For stage, and when we talk to the parents, we will tell them that the prognosis will be okay. For stage 2, 80% normal, but unlikely for the 20% to be normal. So 20% of those babies will be abnormal or die. For the worst case, the stage 3, 50% will die and 50% will not be normal, will have long-term neurological sequelae. How to differentiate between stage 1, 2 and 3? This is a very easy way to differentiate. I will tell you, for stage 1, the sympathetic system is affected. So the level of consciousness, hyperalert, the muscle tone is normal, reflexes are exaggerated, the pupils are dilated as in the sympathetic stimulation, and very important is no seizures and EEG is normal. For stage 2, the parasympathetic stimulation predominates, the lethargy or hypotonia is the reverse. Reflexes are weak, the pupils are myotic, the seizures are common, the EEG is abnormal. So what is very important differentiating point between stage 1 and 2 is presence of seizures and presence of abnormal EEG in stage 2. In stage 3, the baby, the infant is stuporous or comatose, flaccid or hypertonic, but not moving at all. Reflexes are absent, the pupils are fixed or barely reactive. There is this reparation of the baby. The EEG, of course, is abnormal. So from this table, we can differentiate, and we can during counseling the parents, we can tell them that the prognosis would be very good in stage 1 or very bad in stage 3, for example. One point I want to point to you, that one of the causes of absent motor reflex is neonatal, hypoxic, ischemic encephalopathy, and mainly stage 3, not stage 1 or 2. What are the investigations? I think from the previous slides we can know the investigations. They are listed in this slide. Mainly blood count, the blood sugar, of course, the blood urea nitrogen and create, the electrolytes, the liver functions, arterial blood gas, serum lactate, urine output, and if you are suspecting infection, you can do not in all cases. Neuroimaging, mainly the magnetic resonance imaging, that's the very important one. It has a prognostic value. Electrophysiology, the EEG and cerebral function monitor, and the others like EEG, echocardiography, and the chest X-ray. How to manage? Of course, timing is very crucial, and a few minutes of delay may lead to death or suffering from handicap. Prevention, of course, is the best. Support of all systems. For example, the respiratory support, maintain oxygenation and acid-base balance, keep CO2 in the normal range, fluid electrolyte balance, liquid hydration, prevent hypovolemia and hypervolemia. The cardiovascular system, monitor the blood pressure, and if there is need to support the heart, we may give inotropes, may correct hypoglycemia, hypocalcemia. The hematologic variables should be monitored. The GIT, enteral feeding, except if the GIT is not been. Treatment of seizures is very important, and the main three anticonvulsants we use in the neonates are phenobarbital, phenytoin, and midazolam acting. What about the brain? What shall we do? Do we have something to do to prevent continuing damage of the brain? Because actually, although This baby, this infant of 2 hours of age, she has now her brain with many reactions and exaggerated and apoptosis problems. According to the trials, evidence-based medicine, there are only one method to help to diminish the mortality and prevent the long-term handicap, or at least to improve to some extent the long-term outcome. That is therapeutic hypothermia. Therapeutic hypothermia can be done either by whole body cooling or head cooling. This slide shows the head cooling. This baby is covered, his head is covered with a cool cap. We call it cold cap. It's attached to a machine. This machine will deliver water, cold water with a certain velocity in order to cool the body or to cool the head, and the temperature of the baby is measured by a rectal long thermometer to measure the core temperature. Of course, this procedure is very hazardous. It has some complications, but it's proved to be effective in improving the mortality and morbidity. The temperature is adjusted at 34.5 at the machine, and the information will be sent from the thermometer to machine as regards the temperature of the infant. When the temperature of the infant approaches the 34.5, the rate and the temperature of water are decreased, and so on the reverse if the temperature of the baby gets more than 34.5. This process extends up to 72 hours and should be monitored, and the baby can be attached to monitor. It should be attached to monitor, can be ventilated, and can be managed with anti-convulsive drugs if there is convulsion. This is the this is the whole body cooling. The same idea is to cool the body, but using the whole body cooling. And again, the baby has a thermometer, a rectal thermometer, long one, to measure the core temperature. And this slide showed combination of the two methods. To the left is the cool cap, and to the right is the whole body cooling, and this is the machine which is attached to the both either the whole body or to the head. What about the prognosis? Of course, the prognosis will differ from mortality in the first line to no disability in the last line. In between, there may be severe neurodisability, either spastic quadriplegia, cortical 1, affection of the cerebral cortex will lead to spastic cerebral palsy and spastic quadriplegia, or dyskinetic if the basal ganglia are affected, leading to learning difficulties, visual and hearing impairment, growth impairment, and no. What are the predictive factors of outcome? I made a bolding of 4 items. That's of course the clinical grade of HIE. If the clinical grade is mild, the grade 1, the prognosis is good. If grade 3, it's very, very bad. Persistence of abnormal neurologic signs at discharge, usually more than 1 to 2 weeks. EEG and amplitude integrated EEG, that's the functional EEG abnormalities. Also this presence of EEG abnormalities indicate bad prognosis and absence indicate good prognosis. MRI findings, if there is normal MRI, this indicates good prognosis. The other factors include the umbilical blood gas values, the Apgar score, early onset seizures, persistent oliguria for the first 36 hours of life. We will be back to the first slide. The case scenario was the most appropriate next course of action. I will give you answers and you have to choose one of them. Either we do routine newborn care or continue intubation mechanical ventilation due to the risk of apnea, or to do brain MRI or therapeutic hypothermia. Of course, the first two answers are not suitable at all. This infant will need more than routine newborn care. She will need the intensive care. Continue intubation mechanical ventilation due to risk of apnea. No, of course, we will not do intubation and mechanical ventilation except if apnea occurs. Brain MRI, therapeutic hypothermia, I think you can choose one of them. But this is there is some conflict in this scenario, whether to choose this or that. Of course, what is very beneficial to the infant is, so I think you have to choose therapeutic hypothermia, and there is no need for MRI immediately, but you have to choose the therapeutic hypothermia in the first 6 hours. What are the required investigation supportive measures? This is another case, a male infant, full term, 40 weeks, emergency section, placental abruption, that's the cause of emergency section. He also received BPV, positive pressure ventilation, chest compressions, intubated, so he was exposed to the intensive or aggressive resuscitation management. Apgar was 1, 1 and 4, at 1, 5 and 10. So at 5 minutes the Apgar score was 1, less than 3. Upon examination, 30 minutes, he is breathing spontaneously but stuporous. Stuporous means he is in the late stage with absent reflexes. Also, this is the criterion for late stage, stage 3, and non-reactive pupil. So all of these, in addition to the very low Apgar score, are characteristic of severe affection. The arterial pH was 6.9, base deficit -20. Therapeutic hypothermia is started, and this is a very good option. What is the grade and what are the benefits of therapeutic hypothermia to this pair? I think you all after this lecture know that this is great. And what about therapeutic hypothermia? Whether it will decrease the risk of death? Yes, of course. Does it decrease the risk of neurodevelopmental impairment? Yes, of course. But there are two positive or correct answers. This cannot happen. So let us, before we mark upon first or second, to look to the third. Decrease the risk of death and decrease the risk of neurodevelopmental impairment. Okay, that's the correct answer. And the fourth one is not correct. Decrease the risk of death but increase the risk of neurodevelopmental impairment. I hope at the end of this lecture to fulfill all the objectives. We could now define hypoxia, asphyxia, ischemia, illustrate the different causes, what is the effect on different organs, including cardiovascular system, pathophysiologic change in neonatal HIE, we mentioned quickly. We discussed in more details the grading of neonatal HIE, The management was discussed in details, including the investigations of all the body systems, including the brain, supportive measures of all the body systems. But what about the brain? Neuroprotection, and I tell you the predictors of. Thank you very much.